I'm Brandon Carey.
I'm Jason Grady.
This is the Medic Class Citizen Podcast.
Are you ready?
Yeah.
All right, Brandon, let me ask you a question.
What's up, dude?
What is the most dangerous phrase in medicine?
Well, it burns when I pee.
I guess that's pretty dangerous for some people. Maybe not in all of medicine. But I would suggest that the most dangerous phrase in not only medicine, but probably in the history of humanity is that's the way we've always done it. How many times have you heard, why do we do it? Why do we do this? Because that's the way we've always done it. Well, why have we always done it that way? Well, that's just all the way we've done it. And not only in medicine, but really in any business. I mean, this has held us back. It's prevented us from moving forward, and it likely has cost lives.
Yeah. And they may not come out and say those exact words, but their actions, yeah, that's 100%.
Yeah. And I don't know if it's laziness or what it is, but that is often the term that's used.
Absolutely. And if that's true, if we're going to continue to stick to our guns and continue to do that, and we're going to say that's the way we've always done it, well, I guess we should keep doing things like bloodletting for patient care, right?
Oh, yikes. Oh, man. Can you imagine that? The people with OCD that don't like to make a mess now. And not only that, but, let's get the hand drills out and let's continue to drill holes in the top of people's skulls. We got people that don't even like to cardiovert. Can you imagine drilling holes in the people their top of skulls to let out the evil spirits?
Yeah, we have to call Scotty Boletaire and tell him, hey, man, you need to get a cranial IO going here.
Yeah, I think he may have even invented this.
Oh, yeah, probably. Was that him that they're drilling?
Yeah, I think so. That's why he's so goofy.
What is that?
Well, this is pretty sophisticated here. This is important stuff. So if you go to work a cardiac arrest, instead of back in the day grabbing a jump bag or anything like that, medication bag, you would grab something like this. It's it's a way of actually producing epinephrine. They would actually take a tube and stick it up the old rectum there and take tobacco smoke and below the smoke up there, it would actually release epinephrine. It caused the adrenal glands to release epinephrine.
I think that I would hand that off to my clinical third rider.
Yeah, but really the problem why this could never happen again.
Why is that?
Because all the restrictions on tobacco use.
Yeah, nobody would ever enter the field.
That's the limitation.
Yeah.
What's
that? You need one more team lead?
Yeah. Go for it.
And if that's the way that if we're going to stick to that's the way we've always done it, then we should still be driving around these sweet horse and buggies. Check out that World War One, maybe Napoleon War. I don't know.
Yeah, as much as people complain about the trucks they drive now, imagine
some of them feel like that. In their defense, some of them feel like that. Well, maybe that's why. Maybe we are just doing things the way we've always done it.
Yeah, with your 1 horsepower engine over here.
Quite literally. And what is that? That looks like the guitar amp from Back to the Future that Marty McFly blows himself through the wall with.
Yeah, I think that's where they use this. Yeah, that's where they obtained EKGs. I'm not even really.
Is that back in your day? Or is that like
it's my first one I did.
Or is that like Chad Black's day?
Oh.
No, that's Chad Black over there on the little horse and buggy, isn't it? Is
right.
he riding tailboard on the way to a blood pressure check? And I've seen these. I've seen paddles, but I've never used them or seen them used. But I imagine if we were going to continue to do things the way we've always done it, we'd be firing these babies up.
Oh yeah,
every arrest.
How annoying is that? And then the thing that maybe some people would be familiar with, and this is kind of a boomer check here. Some of you young folks don't know what this is, but throw it out there for some of the boomers. These are pneumatic anti-shock garments or military anti-shock garments, masks, pants, We actually literally used to put these on every single trauma. The idea was to inflate them. This is what pilots use, fighter pilots, so they don't pass out.
Wow.
They would inflate to bring blood from the lower extremities back up. They cause pulmonary edema. They caused probably some crush injuries. And so we used to put these on everybody. Now you take them out, and most people had no idea how to use them. They use them for pelvic fractures, and then they had to put little signs on here like "Do not cut."
It looks like something that'd be really fun once everybody's 3 sheets to the wind at a party, start daring people to get into them.
Oh, they're horrible.
Yeah, and back in the day, not only could you just go and pick up some aspirin for your headache, you could also, if you had a pretty nasty cough, you can just go and over the counter grab some heroin.
Oh, it makes complete sense.
Total
Hey, I bet it
sense.
cured a lot of headaches.
Absolutely complete euphoria.
Yeah.
And yeah, I mean, they're probably not coughing anymore either, because they're probably not breathing. So
yeah, it's you think the opioid crisis was bad now. Well, I can't imagine. Yeah. So if that's the way we've always done it, and that's how we're going to do it, we are going to continue to limit ourselves. There's so much that we have to continually learn, and if we don't stay up on it, we will revert back to this. This is the way we've always done it. There's a common phrase that is given in oftentimes in medical schools in the first week or so, and this is probably a phrase that we should be telling EMT students on their first day, paramedic students on their first day, and it's this: 50% of what we teach you will be wrong or inaccurate. Sadly, we don't know which 50%. And, I think we have a problem too in probably in pre-hospital education, is that things just get passed on from, essentially generation to generation. And even if they come out as wrong, they end up just getting passed on. So if we don't know which 50%, then, we really have a problem with trying to figure out what we're doing.
yeah, I love that. That's actually a pretty profound statement. Not quite as profound as some of the statements that come out of Yogi Berra's mouth. Like, it's tough to make predictions, especially about the future.
This guy was one of the most brilliant people.
A lot of people think that he was just funny and dumb, but I think it's just pure wit.
Oh my God. Yeah, you break down some of the stuff he says. That's
yeah.
That's pretty awesome.
One. Yeah, he should have been a doctor. All right, so we've done a boomer check. Jason, I want to run you through a millennial check and see how you hang up. Maybe do a millennial match game here.
You had to go there.
Shout out to Mark
Aram.
Yeah.
The bananas.
So what do the following acronyms mean?
Okay. So I did have to let's see, because my kids text this.
I doubt they do.
I try to be pretty cool, so I text these things too. So yeah, so this is rolling on the floor laughing. I mean, that's that's by the way, in case you missed it, be right back. I think that's what all the kids are texting now.
Yeah.
Oh, LOL, that's lol. Laughing out loud. Yeah. Oh yeah, this is your favorite.
Yes.
Slap.
Sounds
like a plan.
Yes, I use that a lot, actually.
Sounds like a plan. This is phenomenal. Yeah. And then there's some newer ones that are out there.
Whoa, what is that? I've never even seen this one.
Oh yeah. So this is what all the kids are using on TikTok now. So it's I know I'm not a nurse, but I still know stuff. This one, a lot of them are using it's why the face, I think is what this is.
Sure, Jason.
Well, that's
I don't think so. No, I don't think that's right either.
Yeah. So in our
I think really what it stands for is what the fluid.
Trademark pending.
Yes.
Yeah.
Yes.
Okay. So WTF, what the fluid. Okay. So let's talk a little bit about that. So as we go to shock, let me ask you then, what is the end game in shock?
Well, a lot of people think that it's a blood pressure problem, but it's not. A lot of people think that it's a perfusion problem. It's not. The end game in shock is to increase oxygen delivery to the cells and to the tissues, or rather to the tissues and then to the cells. But again, go ahead.
No, I would say there's got to be a better way to explain that.
Yeah.
So
yeah,
blood pressure, perfusion, oxygen delivery.
Yeah.
All right. So hit us up with that a little plainer.
All right. So if we want to get perfusion, which is just getting blood to the cells, and then we have to have oxygen within that blood to oxygenate the cells, right? Well, we have to have enough pressure. We have to have enough pressure in the system. So we have to have enough pump. We have to have the squeeze, right? We have to have the heart that squeezes, and it has to have enough pump. And then we have to have enough volume, right? We have to have enough volume within that within the system. And then as the pump circulates the volume, we have to have an adequate pressure in the container. And then at that point, if all three are good, then we will have perfusion.
Sweet perfusion, the elixir of life.
Yeah, exactly. Yeah, I got my perfusion right here.
Yeah. So then what does this mean if we only focus on one of these things? Like if we only focus on blood pressure, do we give up? Do we actually, if our end game is blood pressure, and we don't care about the other two, what ends up happening?
Yeah, okay, cool. You're getting something to the tissues, but it's not oxygen.
Right. Or so if we perfuse with something, but it's not oxygen, then who cares? If
you are getting substances to the tissues and to the cells that doesn't have oxygen bound to it, you're not doing any good. In fact, it's not that you're not doing any good, you are doing harm. And I think that's the problem.
Yeah, I was just thinking about this, like with this scenario here, the harm that you can cause can be actually detrimental and can be life altering. Like, can you imagine if you went through this whole process and you got here to perfusion, you found out it was non-alcoholic beer?
Right.
What's the point?
That's actually super brilliant.
Or you go through the whole process of making coffee and then you find out it's decaffeinated.
Right.
What's the point?
Yeah, there's no caffeine in my coffee. I don't want to drink it.
The only death that should occur is the person that allowed that to finally happen.
Absolutely. Yeah. And for all you newer students out there, do not make decaffeinated coffee at your stations.
No.
But to Jason's point,
you're fired on the spot.
Right. If whatever the volume is doesn't have oxygen in it, then you're not going to be helping the situation. You're not going to be getting the patient out of shock. 100%.
Yeah. So we got to figure this out a little better. And there's certainly very like academic ways to describe like how people die and then how you're going to fix it.
Right. Right.
Whoa.
Well,
I forgot to put this in here.
I don't know why you did. I told you to take this out. I really didn't want this to be in the video. But it's there, so we may as well talk about it. So so for the viewers who are watching, we have some pictures here. There was a moment that took about 30 seconds of my life away from me. We went out to a conference out in Arizona, and Jason thought the sunset was beautiful. And I was just like, are you kidding me? And he pulled over. He was like, man, we gotta check these guys out. And I said, what guys? And he looked over, and sure enough, on the horizon, there was a camper, and there was a dude sitting in a lawn chair in his tidy whities, and another guy in a hazmat suit. And I was like, I really don't want to go up there. But anyway, Jason apparently knew the guys. Their names were Walt and Jesse. Hung out with them for a little bit, and then they took a picture of us behind this sunset. Anyway, I started sinking. I don't know if it was a weight thing or if it was a quicksand thing. Pretty sure it was quicksand. But I asked Jason for help, and he wouldn't help me. He just said, well, look, man, the only thing I know to tell you to do is to start kicking your feet.
Yeah, and to be honest, it like didn't seem that bad at this point. Like,
no,
I didn't really think like really need to do anything about it. Like, yeah, you're sinking. I wasn't really sure what was going to happen, but like So like, nah, it doesn't really seem like I need to do anything like this, but about this, but if you're going to do something, then yeah, man, just start kicking. Cause that should help you out of quicksand.
Right. Yeah. I was trying to step out of it, but the more I stepped, the deeper I would sink. And you just got irritated with me. I was like, dude, help me do something.
Yeah. Well, it's like, you're obviously not kicking hard enough.
Right.
But exactly. I could tell you too, now at this point, like I was like, okay, this is starting to get bad. So maybe just kick a little harder.
So I did. And then I sank further. And this is whenever I started losing my cool a little bit. I was, I did not like this situation. So, but the only thing we knew to do was to keep kicking.
Yeah. And at this point, then I thought, okay, now it's time to call for some help, or it's time to do, the kicking thing obviously isn't working. Maybe just not kicking hard enough. So if you remember, I was like, no, just kick harder. Now start flailing your arms. And, but I did think at this point, like, okay, now it's time to call somebody and call for help. And I thought, okay, this is going to work. And then all of a sudden you got really quiet. And to be honest, I was torn, because I was like, oh, you quit yelling. Like, I don't know. That kind of seemed like the end game for me. That was, was pretty good, because he actually shut up at that point.
Well, and I'll tell you from firsthand experience, the longer that I was in that quicksand and the deeper that I sank, the harder it was to get out. 100%.
Well, and as I look back now, I think like, well, man, had I intervened right as you went ankle deep, maybe that would have saved you.
Maybe. Well, that kind of brought, while I was under there swallowing sand and breathing in little granules, it was kind of like a flux capacitor moment for me. I was like, wait a minute.
Another 80s movie reference, seriously?
Yeah, that's what I do. The longer I stay in here, the harder it is to get out of it. So maybe perhaps we can look at shock that way.
Yeah, but it's probably not even just, do we change the way that we treat shock? I really wonder, should we change the way we think? Do we truly understand shock well enough? So I'll ask you, is when we treat shock, now, we've all taught this for years. We've all understood this for years, that shock is a blood pressure problem. Yes, it's a perfusion problem, but we define it as a blood pressure at a certain level. And so if the problem with shock is the blood pressure is too low, then should our mentality really be, do you think, about raising blood pressure?
Yeah, I agree. I don't think it should be. I don't think it should be about raising the blood pressure, because sometimes we don't need the blood pressure to get any higher. And I think we can talk about some of those situations here in the future in the coming slides, but it's not a blood pressure problem.
Yeah, the blood pressure is just, it's a measurement that we have.
Yeah.
But we talk about, by the time your blood pressure drops, we're already so far down that, if you're ankle deep in quicksand, you take a blood pressure, it's going to be normal.
Right.
So it may look like, oh, do I need to do anything? No, because the blood pressure is normal.
Right. And, this is something that I don't want people to take and put a spin on what I'm about to say. But truthfully, the blood pressure is just an arbitrary number. Of course, we have hypertension. We know that the damage that's done in hypertension, and then we have hypotension, and we know those ranges for a specific reason. But truthfully, and this is one thing that I love about the people that we've been able to interview on the podcast, such as Dr. Nathan Creel, when they talk about blood pressure is just a sign, but there's an even more important sign, and that's mental status, level of consciousness. If the brain is not being perfused with oxygenated blood, then that's all you need. I mean, you can walk up and see that.
Yeah, and the blood pressure is somewhat like it's a test that gives you an answer that reflects something that's going on inside the body. So even when we take a blood pressure, we're only seeing a single snapshot in time of what a systolic and diastolic is. But so the next question is then, if we have a low blood pressure, are we truly concerned enough about the metabolic condition? Are we only focusing on that blood pressure, or do you think that we are concerned enough about the metabolic condition?
Well, traditionally, and keeping along with the theme of this presentation, if we're going to stick to the way we've always done things, just because we do them that way, no, we're not concerned about the metabolic condition, because all we're concerned about is a number. Okay, well, I got to get this number back up to an acceptable range. But truthfully, just like whenever I was sinking in the quicksand, I was in if you relate that to shock is an acidic condition, right? We have lactic acid, we have a low pH, we have metabolic acidosis. So if we're truly looking at the problem, that's the problem, is the oxygen debt that we are accruing. And the fact that the longer that the patient's in that oxygen debt, or excuse me, the longer that the patient is in that anaerobic condition, the more oxygen it's going to take to get them out of it. So
yeah, I agree. And so if we're only looking at blood pressure, then we can fill that space with enough fluid to get a good blood pressure. But did we change their metabolic condition?
Right, exactly. It's, that's 100% the issue, and that's the paradigm shift that I think we all need to see change.
So talk a little bit more about that anaerobic metabolism and kind of that cycle of what happens. So we understand, like, this is metabolic acidosis. This is a metabolic problem. Shock is inadequate tissue perfusion, but we should probably say more, it's inadequate oxygenation. We can perfuse the tissue with a lot of different stuff, but if we don't perfuse it with oxygen, we continue to get anaerobic metabolism. So go through a little bit of the detriment that happens with anaerobic metabolism.
So yeah, and that's, I don't want to, I'm not trying to insult anybody's intelligence here, but I think it is important to go back and revisit the day one stuff, because this is why we go over the day one stuff. Whenever I say that, I'm talking about anaerobic metabolism.
Yeah, all that stuff. And like, when am I ever going to use this again?
Right. And I've heard it from people. I've heard it from supervisors at departments who just want us to pump paramedics out faster. Why do they need to know that crap? I've literally heard that phrase come out of so many people's mouths. Just get them on the ambulance. They don't need to know that crap. Just get them on an ambulance. All right. Well, this is why they need to know that crap, because it all boils down to this. The fact that whenever you do not have oxygen, the cells eventually start to operate under anaerobic metabolism. If you're operating under anaerobic metabolism, we don't even have to get super specific into the weeds, but you're not producing near enough ATP. And the sodium potassium pump operates off of ATP. So when that situation happens, we know that water follows salt, right? That's an old saying that everybody uses to study and remember things. So if water follows salt, then at some point, there's a lot of salt, there's a lot of sodium inside the cell, and water is filling the cell. Well, if the sodium potassium pump is not working, then the cell is going to swell, and then eventually it's going to rupture. And if that happens to that cell, and then this cell, and then that cell, then all the cells in that area of the tissue begin to die. Then ultimately, if oxygen is still never introduced, then we're still operating under anaerobic metabolism. And that's where that oxygen debt starts, right? So think about it like money. You're in debt. You're in debt above your ears, and that tissue is starting to die. The tissue starts to die, the organ dies, then the system fails, and then the patient dies.
Yeah, and it's that analogy of the quicksand, is that when you're only ankle deep, you don't have a lot of anaerobic metabolism, but it is starting. And what ends up happening is, as you get anaerobic metabolism, as the cells anaerobically metabolize, then we get this whole cascade of events that makes it worse. And then as it gets worse, it makes itself worse because it's worse. And so you get in this downward spiral that if we were to take care of this at the beginning, we can prevent a lot of stuff. But if we're only going after blood pressure, we can fix blood pressure. As I was talking to, Walt out there, I'm like, well, why do you do this? He's like, I need money. I got lung cancer. I got to take care of my family. Well, you can make money. There's a lot of ways to make money. It may be completely detrimental, but you can make money.
Yeah.
You can get blood pressure. That's not the problem. The problem is not affecting blood pressure. We got lots of stuff that can affect blood pressure. What we have a difficulty affecting is metabolism, and especially aerobic metabolism, stopping the anaerobic and actually delivering oxygen to the cells. So we can increase blood pressure, but if we don't increase oxygen to the cells, then all you do is pat yourself on the back, say we got the blood pressure up, and then the patient dies.
Yeah, that's almost like epi during cardiac arrest. Oh, well, we got a
pulse
heart
back.
Yeah, we got a pulse back. Well, you can give a heart enough epi. You can give a rock enough epi. What's the old school saying? Help me out here.
I'm not old school, man. I don't know.
Oh, sorry. Something about pulses and rocks and epi. So yeah.
Give enough epi to a rock, get a pulse out of it.
Oh, like that. Yeah, that's it. Yeah, thanks. Appreciate
it. So we get this idea of fluid resuscitation for hypotension. This has been, it has just been in every textbook, in every national registry check off until a little bit recently. But this comes from the ACLS gospel. Did I use that right? I'm sorry. Yeah. I'm sorry. I meant guidelines. I get those two words. Confused. So the ACLS gospel. Guidelines. I meant guidelines. So in 2010, if you looked at post arrest, and remember, the number one cause of sudden cardiac death is a STEMI. Okay. And so if you have a STEMI and you are in cardiac arrest, when you get ROSC, you can absolutely predict that you're in cardiogenic shock. By nature, you're in cardiogenic shock. You went for a long time with little to no perfusion. You get a heartbeat back, yet your muscle, the heart muscle, is not strong enough to probably have sustained ROSC. So you have a blood pressure of 70. So what do you do in post-arrest algorithm? 1 to 2 liters of normal saline or lactated ringers. And that was the first, that's first line treatment. This is something that we preached as gospel for so long. And then 5 years goes by and you would think, oh, okay, well, a lot of science has changed. You'd be wrong. No science has changed. It wasn't until 2020 that they came out with the new gospel, guidelines, that says that you can go to a vasopressor or an inotrope, but it still says administer crystalloid first. So it's it's a little bit confusing. And then to maintain a blood pressure of greater than 90 or a mean arterial pressure of 65.
So close.
So in 10 years, and prior to 2010 as well. So when we say, we're not really at fault in EMS for why we give a lot of fluids, because this is the way that we've been taught. And then probably one of the most detrimental things is the old 20 milliliters per kilogram.
Yeah. And it's unfortunate. And, I'm not going to knock anybody for this, because this is what I was taught. This is what they were taught. And, this goes back to decades. We just pulled up ACLS guidelines. Is it gospel or guidelines?
I can't. I think it's. I can't remember. I get it wrong every time.
Yeah, me too. But we only went to 2010. I bet if we were to dig back even further, goodness gracious, man, that, and along with the trauma courses. So, we've been giving 20 mLs per kg for adults in any type of shock, regardless. It doesn't matter what the cause of it is. It doesn't matter if it's a pump problem, a volume problem, or a vessel problem. We've been slamming fluid to folks for decades, ever since we've been in existence, pretty much. So with that to say, I can't blame my instructors, because they were taught that way. I can't blame what I taught my initial classes, because I was taught that way. But thankfully now, I think we're starting to know a little better.
Yeah, I think this goes to that 50%. And it's not, this is medicine. This is, as we learn new things, we change. But we have to be able to learn them, and we have to be able to change. So the 20 milliliters per kilogram came from pediatrics. And it wasn't to bolus large amounts of fluid. It was actually to prevent bolusing large amounts of fluid. So the 20 milliliters per kilogram was to prevent fluid overload, not to show that we should give a lot of fluids. Yeah. But like you said, Brandon, this was a myth. There was very little or no data behind it. And we're not, I mean, look at myths. I mean, with the internet now, there's lots of myths out there, and there's a lot of myths that we actually believed. Probably one of my favorite myths that I bought in hook, line, and sinker was that Mr. Rogers here, you see the sweaters?
Yeah.
You know why he had to wear sweaters?
No.
Because he was a tatted up military man. Yeah, killed a lot of people.
Man,
and,
I love it.
With all those tattoos and his his M16, his AR-15.
Check out that PBS tattoo right there. That's sweet.
Hey, I have one of those actually.
I bet you do.
Public radio.
I bet you got Oscar the Grouch. Never mind.
Oh,
Never mind.
but it's not our fault.
Right.
There's a lot of other myths that we believed.
Right. Yeah. Like we landed on the moon, right?
Yeah, right. Man, that has been debunked so many times.
Absolutely.
Yeah, no, we did not land on the moon. And Mr. Rogers does not have tattoos,
That's
nor
right.
was he in the military.
Yeah. Yeah. And another another myth that we believed is that normal saline is actually normal.
Yeah. Yeah, it's not normal. The pH of normal saline is 5.4.
That's good.
Yeah. Oh, it's great. So you're taking, as we talked before, let's see, you have no blood pressure, which means you have anaerobic metabolism. You're burning without oxygen, which give off lactic acid, which is now you have metabolic acidosis. And so how do we treat acidosis? Let's give a fluid that is acid. Because that's the
maniacal laugh as we kill patients for 4 decades. And another issue with this, and again, why do we call it normal saline? Well, in fact, the sodium content in normal saline is 10% higher than what it is in human blood. And even worse, the chloride content is 50% higher. And those solutes, both of those, water follows both chloride and sodium. So that's an issue.
Yeah, which means in the kidneys, I mean, this is the whole reason we give a loop diuretic to intentionally move this stuff in and out of the cell. But when this happens, the volume expansion here from that saline infusion can actually cause renal tissue ischemia. And as we know, as you start circling the drain, your kidneys are responsible for regulating this acid base imbalance. And once your kidneys go, you become acidotic, which makes you more acidotic, and then you eventually die. So when we talk about this quote unquote normal saline, it gives us a false sense of security. And then also, when I remember, back probably before a lot of you were born, I recognize that, way back in the 1900s, actually. When I went to EMT school, I'll never forget this. The standard was, first of all, mask trousers, just because they look cool, probably.
Yeah.
But it was.
Did they have a large size of those, or would I just be screwed?
No, you probably would have survived. Because you couldn't get it.
Good point. Well played, sir.
But the idea was with blood pressure's low, what do? Well, we take out our 14 or 16 gauge needles, and we put them in every large bore access that we can get.
Yeah.
And literally the mantra was give them enough fluid until they bleed pink.
Mm-hmm. Yeah,
that
turn them into Kool-Aid. Oh yeah.
Oh yeah.
And by the way, I'm going to do a millennial check there. It's
no, they don't have Kool-Aid.
It's literally.
It's not literally.
No, it's literally.
Literally.
Like anytime us millennials overuse the word literally, it's like, bro, literally, like I was literally bleeding Kool-Aid.
Yeah. And so we thought that was the right thing let me say, we didn't think that was the right thing. We knew that was the right thing.
Oh yeah.
So when someone was on the brink of death, we knew we could give them this magic elixir. So when we thought of saline, this is what we thought of.
Oh man, check that out.
This Dr. Thackeray's miracle cure-all.
I love it.
That's stupid, but real in reality, it's Dr. Creel's salt solution of death.
I remember back in the day going to some good shows, and like anytime somebody was doing that metal chug, you like riding your motorcycle. But anyway, yeah. It was when we played that silly little bar piano and we had the medicine man. I mean, just think about that. Think about back in the day, whenever, an old Western town, this Joker would ride up with this awesome carriage and be selling stuff out of the back of his little horse and buggy wagon, miracle cure-all medications, snake oil. And now it's it's a euphemism. A snake oil salesman is someone that comes in and just sells a bunch of nonsense. Today you might call it essential oils, but sorry, or crystals, healing crystals,
magical crystals.
Yeah.
But in reality, when we give saline to this, we're actually likely harming patients, or let me be more specific, when we give too much saline in order to treat the blood pressure only, really, and this is the term that I love right here, Dr. Creel's Satan's salt solution of death.
Mm-hmm.
And we're going to talk. Well, I think we'll talk more about that. So we don't even know, it's not just myths about Mr. Rogers landing on the moon. We actually have fluid myths, that fluid raises the blood pressure by increasing cardiac output. We talk about, so blood pressure is a component of cardiac output and systemic vascular resistance. And so if we raise the cardiac output, we raise the blood pressure and everybody's happy. When in reality, when we give fluids, this is what happens. So there are two randomized controlled trials that show that it was actually the cold saline that raised the blood pressure. That was actually the vasoconstriction increasing systemic vascular resistance. It was not the cardiac output.
Yeah. And let's talk about that for just a second before we move on. Let's talk about that cold saline, because if we think about it, if our normal body temperature, if our core body temperature is 98.6 degrees, and we just grab a bag of fluids off of the truck, what temperature is that fluid?
Yeah, even quote unquote room temperature is a lot cooler than 98.6.
Absolutely. So you're infusing something, and we're going to talk about the Triad of Death here in a little bit, but you're infusing something, not only like you talked about earlier is super acidic, but likely it's more than 20 degrees colder than what the human blood is, or is supposed to be. Yeah. For adequate clotting. So anyway,
yeah. So it's not. It wasn't the fact that the cardiac output went up, and then in another trial, it showed that the initial fluid bolus did show some benefit, but after that, repeat blood boluses of fluid did not increase the blood pressure. So the blood pressure did not go up, yet the rest of that fluid was actually harming.
And myth number 2, whenever we're talking about fluid resuscitation, is that increased cardiac output equals increased oxygen delivery. Well, it's simply not true, because if you're achieving that increased cardiac output with crystalloid infusion, 1 liter of fluid has been proven to cause the following. So if you increase the cardiac output with 1 liter of fluid, okay, you're only increasing it by 15%. You may think like, okay, it may make you feel better as the provider, which I think is what a lot of this boils down to. Unfortunately, we want to do something. We want to feel like we're doing something. So, all right, so we infuse 1 liter. We see an increase of 15% in cardiac output. However, what we don't see is a decrease in hemoglobin saturation by 16%. That's pretty bad.
Yeah. So you have no change in oxygen delivery. And if you look at that, it's actually a percentage lower of hemoglobin than you started out with. So you actually made the situation worse.
Yep.
You dilute that that blood that's there, and you dilute the hemoglobin, and you decrease the oxygen capability. So yeah, you increase the blood pressure. You can certainly high five over that, but you didn't increase anything for the patient.
Yeah.
And then the other thing that and really, I think this is what it comes down to is all fluid bad? No, not all. I don't think all fluid is bad. A little bit of fluid is probably good, but what we end up doing is volume overload. For anything really other than hemorrhagic shock that we'll talk about in a little bit, when the volume is the volume, 5-6 liters inside the body is what you need. So to increase that, and or to, if we lose volume and we replace the volume yet overshoot it, and we create volume overload, I know we talk about the number one thing that we look for is pulmonary edema, but that's actually, pulmonary edema for volume overload is kind of like low blood pressure for shock. By the time you get to pulmonary edema, you've overshot your volume tremendously.
Your patient's probably dead.
Yeah, or they are so far gone that it doesn't matter what you do at that point. So if we think about what happens on the venous side, because of course that's where we're increasing the volume on the venous side. Every time we overload that volume, we increase central venous pressure. And as the organs try to perfuse, that increase in central venous pressure causes the organs to not perfuse as well. And so with extravascular fluid overload, we get these fluid shifts like Brandon talked about, as it rushes in and out of the cell, we get this fluid overload, and then we get organ failure. And when we get multi-organ system failure, well, at that point, you're done.
Yep.
So why is it that we get so fixated, Brandon, on fluid?
Well, there's an old saying that I think fits very well in this situation. Whenever all you have is a hammer, everything looks like a nail.
Yeah. And then even, I think a little scarier than that is, even when you are presented with something that may be better, we still end up holding on to our traditions. Mm-hmm. Again, because that's the way we've always done it. There's a lot of reasons we become paramedics. One is, to intubate, to give medications, to do certain things. And sometimes I think we end up holding on to this. I do this because I can.
Yeah. And can we just stay right here for a second and dissect this a little bit? We kind of hinted earlier, why do we do this? Why, as a profession, is it a pride thing? Is it an ego thing? Like, you mean to tell me I've been doing something wrong? No, I've had some good patient outcomes anecdotally by doing things this way. I'm going to keep doing it like that. Or
yeah, and
like you said, is it a laziness thing?
Yeah. Yeah, that's a difficult thing of, I saw this work one time. No, the patient probably survived despite your best effort to kill them.
Yeah. And when you talk about laziness, I think we're talking about training, because it's hard to learn new things, or it's hard to revisit things that were given up on decades ago. Because when we talk about earlier, I do want to clarify, we haven't only given crystalloid fluid throughout the entire history of paramedicine. There was a point in time where we hung plasma in the battlefield, and that was a common practice for hypotension.
Yeah.
But then we got away from it. So I think there could be a little bit of decreased motivation to train and to memorize new things, and to tailor your practice to evidence-based medicine. So
yeah, and let's take that in a little more academic way now, a little highbrow. There's another statement in medicine that says, just because you can doesn't mean you should.
Yeah.
Okay. I don't know if many have seen the cinnamon challenge.
We got shot, guys. We got shot, me some of that. Oh, yeah, no more. I think that's good. You ready for this?
Yes, sir.
Goodness gracious.
Let's go. Ready?
Millennials.
1, 2, 3.
You gotta love them.
Oh, ow. Did you see that come out of that kid's nose?
That's gonna be there for a while.
Oh my god. That Joker's gonna have a sinus infection for like a year.
I say just because you can doesn't mean you should, but man, it sure makes her some good internet.
Yeah. Thanks for some good internet.
I mean,
did you just make that up?
Let's be honest. If it wasn't for stupid people, we wouldn't have a job. You know, let's be careful. We don't want to limit things too much, but
right.
All right. So when it comes to cardiogenic shock, obviously we know cardiogenic shock is a pump problem. When you go into cardiogenic shock, you have plenty of volume. That volume didn't go anywhere. Your container is just fine, but your pump is not working. And so often our first goal and our first reaction is we got to fill up the pump. We got to fill up the container. Yeah, okay, we're going to give some pressors, but let me ask you this, Brandon. How many times do you run into this? Well, I cannot give a pressor until I fill up the pump or the container, excuse me.
Dude, if I'm being transparent, every day, all the time, even in the emergency department with physicians. Hate to say that, but that's the top tier. So if they are thinking that, and I guarantee you, if you were to hang a pressor without giving a ton of fluid and then you get shamed by a physician, are you going to do it again?
Yeah, probably not. But again, I would just ask the question, well, where did the volume go? You had 5.5, 6 liters of fluid in your body, and then you went to cardiogenic shock. Did it magically disappear? And now all of a sudden your liter of saline is going to save their life? No. And in fact,
you give them bubble lungs.
Oh yeah, and stop their coronary perfusion. And you give a lot of fluid to this. The good news is you solved their problem.
You took the pain away.
You took the pain away. Yeah. They no longer have pain. So the right side of the heart is still pumping. It's pumping around to the left ventricle, yet the left ventricle can't pump it out. So now the left ventricle blows up like a tick. And so the more fluid we give, one of the analogies that we use is if you have a pneumothorax and your pleural space is filling up with air, do we just keep bagging that patient more and more and more? They're getting more hypoxic. So obviously we just got to add more and more air. Well, no, because that air is going in and it can't come out. The same thing with cardiogenic shock. The fluid's going in, yet the fluid can't come out. So preload increases, myocardial wall stress occurs. We get decreased coronary perfusion and the blood pressure goes up. I'll give you that. But then they die. So when we get a patient with in cardiogenic shock and their blood pressure is 80 and we say, so you got to give a lot of fluid, our answer should be
WTF. Hold on, let me say that better. WTF. Sorry,
it's like a radio station.
Exactly.
Yeah, so they say give a lot of fluids.
Need some backup singers.
Yeah.
WTF.
But BDTOWFI.
What?
Which of
course. What are you doing?
But don't take our word for it. Here's a couple references that you can look at on cardiogenic shock and using a percutaneous LVAD.
I like that. So, all right, so let's talk about hemorrhagic shock for a second. When we talk about hemorrhagic shock, of course, we're talking about a volume problem, right? So at this point, we are losing what is carrying the oxygen, what is helping clot. We are losing so many different things in whole blood. It's not even funny. But again, if we replace it with something that is not that does not have similar characteristics, then we're not returning the body back to aerobic metabolism. We're simply replacing volume.
Yeah, so we had a chance to speak a while ago with Dr. Nathan Creel, who is a trauma surgeon up in the Northeast Georgia area. Remind us what he said. He had a statement that really just changed the way that I thought about hemorrhagic shock and volume replacement. Remind us what he said.
Yeah, and truthfully, man, he said a lot of things that were slam dunk, like mic drop moments, and I want to give him credit for pretty much everything that I'm about to say. So first off, there is something that I want to dive into that he really discusses well, and that's the Triad of Death. The Triad of Death is comprised of hypothermia, coagulopathy, and acidosis. And so essentially, whenever we have that, whenever we pump the patients full of fluid and we increase the acidosis and we drop their body temperature, but more specifically, whenever we increase the coagulopathy, it becomes so bad, and this is quotes, it becomes so bad that the sutures continue to bleed faster than we can put them in. That blew my mind. That blew my, I mean, can you just sit there and picture him putting those sutures in and then it's still bleeding Kool-Aid?
And just each time going, crap, knowing that whatever treatment he's doing, because of the volume overload, whatever he is doing is not working.
Yeah. And this is coming from a trauma surgeon, folks. This is coming from a trauma surgeon who works at a regional level 2 trauma center and a trauma surgeon who is also a medical director for a very aggressive service. This is a credible source. So I can sit here and imagine how deflated that can make you feel. Like
frustrating.
Yeah, man. Like we want to do everything we can for our patients. We want to be aggressive. We're here in surgery, man, whether it's EMS, whether it's the emergency department, somebody packed this patient way full of fluid.
But we got the blood pressure up.
Right. So I want to talk a little bit and share a little bit more about what he was talking about. And, you know, we've already mentioned several components of this Triad of Death, but I want to kind of bring it all together here because this is where it's pertinent. So as Jason was talking about, with the average pH of saline being 5.4, 5.5, somewhere in there, that's going to make the patient incredibly acidic. Well, the problem with that is the rest of the hemoglobin that you have left in the body. Let's say that you've controlled the bleeding, but now you're pumping in crystalloid, which is very acidic. Oxygen does not bind well to hemoglobin in an acidic environment. So problem number one, we're pumping in acid and we are discouraging the oxygen from binding to the hemoglobin. That's a huge problem. And like we saw with that study that we showed earlier, with 1 liter of crystalloid, you have a 16% decrease in hemoglobin.
Yeah, it completely dilutes it.
Yeah. It doesn't decrease, it dilutes. Thank you. That's actually very important to clarify. And then hypothermia, like we were saying earlier, even if you take, you're not guaranteed. I mean, if you have fluid warmers on your ambulance, how many of you are actually measuring the temperature of that fluid? You know, hopefully it's warm. Hopefully the warmer is actually working. But let's say if you grab it out of the back and it's not in a fluid warmer, you infuse a 70 degree, 68, 65 degree fluid into a 98.6 degree body. Well, again, hypothermia creates coagulopathy. It creates a breakdown in the clotting cascade so that the wound can't heal. Therefore, the patient continues to bleed out, continues to bleed. And so then you're starting to pack in fluid, which is going to increase the pressure, which is going to blow out any clots that start forming. So, you know, one thing that he said that was another slam dunk, like Michael Jordan from the free throw dunk. How about that? That's some 80s sports for you, Jason. I believe that was the 86 slam dunk contest.
Something like that.
I think so. It was him and Dikembe going head to head. If you replace if you have a bleeding patient and you replace their volume with anything other than blood, you are doing harm. Anything other than blood.
Yeah, that's huge, but that is such a difficult thing to do, to give blood products in the field. It's been very limited. It's a limited supply of blood. Yet there is currently now in 2021, there actually is a trial going on in the state of Georgia to see if blood products and plasma, and there's one service giving whole blood, whether or not that's feasible. Can EMS do a good job of maintaining that blood, of keeping track of it, the temperature and everything? And then can EMS appropriately deliver it? Can they deliver it safely? And does it have decent outcomes? So I think we'll be excited to see what the results of that are. But I think it's safe to say that so far, here we are at the at the end of 2021, that it is showing a lot of promise. EMS is doing a really good job with being able to pull that off.
Yeah. And there are a couple other points that he talked about that I'd like to discuss really quickly, and that's permissive hypotension. So, if you're listening to this and watching and you're like, oh, well, that's great. But let's say I work, and to add on to Jason's point, the services who are involved with this trial and with this pilot study have very long transport times in comparison to like metro, urban, transport services. So instead of a 5, 10, 15-minute transport, we're looking at 45 minutes to an hour, maybe even more sometimes. So let's say that you're working for a metro area service and you feel like, man, we're never going to get blood. Why would I ever have blood on my ambulance? I have a 10-minute transport. What you can do in this situation is permissive hypotension. Don't make the problem worse. If you don't,
for years it's been this, titrate a blood pressure to 90 systolic, but
correct.
Now I think we're learning that maybe less blood pressure is okay. What is that permissible type of, where is that number to say, hey, we can keep a blood pressure this low and still have the patient survive.
Yeah. And what I tell my students is when you're thinking about permissive hypotension, you're giving yourself and your patient permission for that hypotension. Because again, like we were talking about earlier, I really do think part of what the fluid problem is we feel like we're doing something. We feel like we are helping because we're doing something whenever we pack them full of fluid. But truthfully, permissive hypotension, per ATLS, Advanced Trauma Life Support, and PHTLS, and even the paramedic books, thankfully, the most recent versions of various titles in the trauma section, they talk about maintaining a systolic enough to have a positive mental status. And, there's various numbers that range in MAP of 60, 65, somewhere in there. But the most important thing is, can you monitor that mental status? If you're maintaining that mental status, if you have an improvement in mentation, the brain is getting oxygenated blood.
Yeah. And it's about oxygenated blood. So crystalloid solutions do not work well in hemorrhagic shock. So when they say you have to give a lot of fluids to hemorrhagic shock, WTF. All right. But don't take our word for it. Here are a couple studies that show the detrimental effects of resuscitation, or specifically over resuscitation, on trauma patients.
All right. So we can knock this out really quick. This isn't going to take long at all. This is really cool. Whenever we talk about septic shock, of course, we're talking about the container, right? We're talking about widespread vasodilation throughout the body, which causes a relative hypovolemia. So when we have that, we know that the problem is that all the vessels in the body have dilated. So what's been the treat? What was the, well, did they even know about sepsis alerts whenever you went through paramedic school?
No, not really. Sepsis is somewhat of a new phenomenon on how to treat it,
especially
rapidly.
in EMS. Yes.
Especially in pre-hospital setting.
Yeah. And that's, I was kind of busting your chops, but I was also being serious in that, whenever I went to medic school back in 2013, 40 mLs per kg bolus of fluid as fast as you can. Then it decreased down to 30. Now it's down to 20. And the problem with that, let's talk about what happens. If you try, again, like you said earlier, the fluid's not going anywhere. The fluid, whenever we have widespread vasodilation, the capillaries, which are simple squamous epithelium, they start to separate, and that fluid starts to go into the third space.
Start leaking.
Yeah. So, and you think about what you're doing to the organs. All that fluid and that edema, we think about edema in our hands and our feet. Think about your liver. Think about your kidneys. Think about your renal veins. All of that stuff is becoming edematous, and oxygen can't go across that.
Yeah. So we're really getting away from fluids or massive amounts of fluids in septic shock. So when they say you got to give a lot of fluid in septic shock, WTF, but don't take our word for it. And I think this is worth checking out. Fluid resuscitation, the great 30 milliliter per kilogram hoax. But, really, this comes down to one thing. WTHWDO. Everyone obviously knows what this stands for.
Absolutely.
I don't have to say it, but I will, just because it stands for what the heck do we do? When it's so they're
You're going a little overboard, man.
Am I? Are these original? So there was a pretty famous, well-known trial called SOAP 2, and it looked at pressors, the use of pressors in 3 specific forms of shock: hypovolemic shock, cardiogenic shock, and septic shock, and whether or not Levophed or norepinephrine works better than dopamine. And it showed pretty clearly that pressors are better, and we should be giving Levophed. But that is not the only thing that we should be doing on things like SOAP 2. We should be continually looking for what's the next trial, what's the next amount of research in order to be able to change what we do. And so Clovers is the next thing, Brandon.
Yeah, and that is super, super awesome, because Clovers is actually looking at, they're still collecting data right now, and they should be publishing their findings in June of 22. COVID slowed down the publication process. They were supposed to be published in 21. However, let's talk about Clovers. Crystalloid liberal or vasopressors early, resuscitation and sepsis. So essentially, we have a study looking at treatment involving up to 5 liters of crystalloid infusion versus 500 milliliters along with early vasopressor administration. So even in the sepsis world, we're looking at decreasing that amount of fluid that we are slamming into our patients. Right now, the data that we have about this study, or excuse me, the information that we have about this study, we have 2,320 participants. It is randomized. It's an open label trial, and it should be, like I said, completed around June of 22. So
yeah, and 5 liters seems like a lot, but I guarantee there's a lot of sepsis patients that are getting 5 liters, or maybe even more.
That's a whole blood volume.
Yeah,
that's a whole body.
Yeah, imagine what you're doing to that to the hemoglobin. Not to mention, I'll just throw out too that to hear some of the critical care docs talk about what they end up having to do with dialysis. They have to literally put patients on dialysis because they're volume overloaded. Their kidneys are just engorged with fluid, and there's more fluid behind it coming, that they end up having to spend sometimes several days on the front end of treatment just getting fluid off these patients. This is not the amount of fluid that Lasix can take care of. They literally have to put these patients on dialysis because of the volume overload. So this will be exciting to see what this result is, and whether or not we should restrict fluid.
Awesome.
All right. So in summary, when all you have is a hammer, everything looks like a nail.
Yep. And fluid overload or slamming fluid to a patient may give you a short-term gain, but it can kill the patient in the long term.
Yeah. So maybe this really comes down to, we just need more tools in our toolbox. Get rid of that hammer and let's put some more stuff in there. Maybe some stuff that we're not familiar with that we actually have to learn about.
Yep. And to steal some of Jason's terms from the past, we need to stop working in silos, and we need to start actively working in a system of care to provide the best treatment. The days of, well, I dropped them off there with a pulse, what you did with them when you get there, those days are over. We're working as a team. We are in a system of care.
Stop high-fiving when the blood pressure goes up. High-five them when they get home and made a full recovery.
Absolutely.
So when they say you have to give a lot of fluid,
WTF.
Thank you very much. Here is our contact information, and you can check us out at medicclasscitizen.com or any of our social media.
Tell us about that social media, Jason.
That would be FaceSnap, Chatgram,
and Instatube.
And currently on MySpace.
That's right. You still are, probably. Thanks, everybody.